here from Michigan. Dr. Emily Mathias is with us tonight to talk about pediatric respiratory emergencies and airway management. She is a faculty member at the Department of Emergency Medicine at the U of M here in Michigan, the University of Michigan. She works in the Children's Emergency Services at CS Mott Women's and Children's Hospital. This is one of our leading pediatric centers in our state. She has many interests, but especially include supporting community emergency departments' preparedness for pediatric emergencies. She loves focusing on evidence-based readiness efforts and education. She has provided numerous discussions for many of our EMS pediatric champions in the past, and she helps counsel the Michigan EMSC program on pediatric emergency medicine manners, and also helps to steer development of pediatric champions in our state. I'm very excited to welcome her. Emily, you can feel free to take control of the screen and I will stop my share.
All right. Thanks, Sam, for that introduction.
You're welcome.
I'm sharing through my computer, and that is because I, as much as possible, I really like to make whenever I lecture interactive. So I'm going to be presenting with Slido. I'll kind of give you guys an introduction to it and an opportunity for you to sign on and use it in just a minute. But anyway, we should just get started because I only have an hour here on this super broad topic. But yeah, I'm going to be talking about respiratory emergencies and airway management in pediatric patients. Thanks to Dr. Mishra and the organizers of this event for giving me this opportunity. It is something that's topics near and dear to me, and it's something I deal with almost every time I set foot in our emergency department. So very familiar with it. Okay, so why are we having this discussion? Number one, because true respiratory emergencies in infants and children are very stressful situations for everyone involved, let's be honest. Unlike in adults, the most common cause of cardiac arrest in children is respiratory arrest. So identifying respiratory emergencies and treating them early can help prevent future badness, right? Number two, I used to say respiratory emergencies in children were low frequency, high risk events, but I don't even know how confident or even safe I feel saying that anymore. I don't have concrete numbers for you, but I definitely think that they've gone up in relative frequency, especially after living through the triple-demic of last fall and winter, right? Additionally, we know that the number of pediatric patients with complex medical needs, such as patients who are trach and vent dependent, who receive care at home, is on the rise in the United States. So the likelihood of you having to interface with these patients is undoubtedly going up. And then also, I think it's really important to talk about this because your early interventions matter, right? Early recognition leads to earlier and often less invasive treatment. So when I was initially asked to give a lecture on respiratory emergencies and airway management, I was like, okay, so how many hours are you giving me? Because it's, like I said before, an incredibly broad subject area. So I kind of took the liberty to pick and choose what I think will be the most helpful for those practicing in the community to know. I can promise you it will be relevant and not too in the weeds. My hope is that one day you will be treating a kid and something I said will be helpful for you. So kind of that's kind of where I set the bar for this. And then also just a little bit about me. I've realized in recent years that a lot of the joy and satisfaction that I kind of garner from my job is through opportunities to empower others, whether that be new parents of an infant that I'm seeing, or new learners. And I kind of hope you. So I 100% believe that you're all capable of taking care of children and infants with respiratory distress. And I believe that, and I hope that you believe that as well. So hopefully this works. It hasn't let me down yet. This is a program that I use. There's a QR code. You can join at slido.com right on your computer. And this is honestly, what I really like about this program is that I have made like all of the responses that I'm going to ask for and just like opportunities for you to ask questions. It's all anonymous. because I just want you to feel, comfortable asking that question that you're just like, this is a dumb question, I don't want to ask it. But yeah, please ask away. And it's all going to be anonymous. It's just going to pop up. And then I can just kind of respond to it, and I don't even have to know who asked it. So I'm just going to give you a minute to join. And please do, like, the more interactive we are with this, I think the more we're all going to get out of it. So. All right. From what I remember, I think there's going to be like a sidebar with your joining instructions on the side. But so kind of let's just start out with, what are some of the thoughts that pop in your head when you get called in or called to see a child in respiratory distress? Etiology, okay. Intubation, oh my gosh, yeah. Oh shit, definitely scary, yeah. These are all, panic. Exactly. So this is kind of what this program's creating right here is a word cloud. So the things that are coming up more often in the responses are going to be are things that are highlighted in green. So you will see, and this is why I do this, is because for so many people, you're called in to see a patient, a kid who's having a hard time breathing, and it's causing panic, right? Anxiety. So this is for me to show you, you are not alone. Stay calm. I like that. Call RT. These are all very good observations. Scared parents, certainly. Fear grouping. Okay, yeah. Good. Well, we're going to be definitely touching on some of these. Hopefully, we can just, I guess my hope is that maybe by the end of this, some of the overwhelming anxiety and panic that you feel is maybe lessened a little bit. Okay, so let's just start with a little case. You're called, it's not really a case, it's just kind of an intro, actually. You're called in to see a 4-month-old infant. The mother reports that the baby is having trouble breathing. And that's all you got, right? Because that's what it seems like, very bare bones information. You go in. So you're like, okay, here I go. You walk in to see the infant, probably feeling all of that stress and panic. Without touching them, what observations would suggest that this is a child in respiratory distress? Retractions, absolutely. Yep. Yep. Skin color, that's another really good. Yep. Are they quiet? That's a really, really good observation, whoever made that. Because a baby who's upset should be screaming their head off, right? Quiet babies scare me, absolutely. Chest movements, perfusions, grunting. Thank you for being so engaged with this, guys. I gave a lecture earlier to some emergency medicine residents, and oh goodness, no one would respond. So this is like making me feel so good. Thank you. Yeah, nasal flaring, seesaw breathing, certainly blue. Yeah, drooling. Eye color. I'm wondering if maybe you meant like if they have sclerolicterus or something. But big blue-eyed babies, I love those too. So okay. Lethargy, absolutely, yeah. So these are all, you guys, these are all really good observations. And this is, before I even set, hands on the infant to examine them, these are exactly the things that I'm looking at as well. So this kind of brings about the idea of this thing that many of us are probably familiar with, this pediatric assessment triangle. And I actually think that this is a really helpful tool for providing you with a framework for assessment when you're trying to gauge how critically ill this child actually is. And I really do love it. I talk to, like, whenever I'm working with a new resident, I kind of introduce it to them and talk them through it and the value in it, because you can basically do it from the doorway. It allows you to kind of like sneak a peek at the kid before they see you and inevitably start screaming, right? Or hopefully start screaming. So again, things that you had mentioned in last slide. So appearance, I'm looking like, are they awake, alert, responding to their environment, right? A baby who seems upset by your presence is actually that's a reassuring thing, because like that's a normal developmental response for a young child or infant. If they literally can't garner the energy to have that sort of response, that's when you get a little bit worried. Are they responding to their environment? Are they moving spontaneously? Are they like limp in their parents' arms? So just that basic appearance, really important. Circulation, how does their coloring look? Are they pale? Are they cyanotic? Are they mottled? Are they gray? Nobody likes a gray baby. So just, again, something that you can just like quick glance with your eyes and kind of make this assessment of, is this an ill child or not? And then work of breathing. A lot of you had mentioned retractions and head bobbing, grunting. Those are all signs of increased work of breathing. Other things I think that were mentioned are the posture. Like, are they like bracing themselves and just like, looking very uncomfortable? That is, it's actually something that I see often with kind of a little bit older kids in respiratory distress. It's like, you have a 5-year-old that normally parents are like, normally they're running around the room and playing, but they're just like, they're stoic on their bed, basically using all of their energy to breathe. So looking at their posture and their positioning is really important. Are they crying? Are they and then talking? Just talking is another good sign for a slightly older kid. If they can talk through a whole sentence, that means that they're not, that their work of breathing is not extreme to the point where they can't talk. And if they're just giving everything that they got to take a breath is not good. Infants, I look for things like head bobbing, irregular breathing patterns is certainly of concern, especially when they're like in the first few months of life. And then certainly retractions, where are they, how significant are they? And then nasal flaring is something that you also see. You can just observe and make that assessment. How sick is this child? How significant is their respiratory distress? So you walk in and you see a baby and you're like, just without even laying hands on this child, I know that this baby is in respiratory distress. Now what? So I'm going to try to hit on some high points and hopefully helpful tips and tricks for each of these categories for you. So it is helpful if you can categorize them kind of into upper airway problems versus lower airway problems, maybe a little bit of both. And then, or is this actually a heart problem? I don't get too much into that because, again, that I feel like that is a whole other lecture on pediatric, like cardiogenic shock, but or is this something else that's kind of mimicking respiratory distress? So upper airway issues. Kids definitely have floppy airways. The pediatric larynx is composed of non-ossified cartilaginous structures. Hence, the whole structure is softer and more pliable than it is in adults. And this increases the risk of airway obstruction. It's also important to note that not all that stridors is croup. I used to have a video, like a really good video of stridor, and I was having a hard time finding it. But stridor often starts inspiratory and progresses to biphasic. So stridor, we typically think of it as inspiratory, but I find that those kids who are really truly in distress, it's more biphasic. So parents, will be like, their voice, their cry is different. They'll say maybe they sound like they have a frog in their throat, or again, like that they are hoarse, talking more hoarse than usual. One kind of trick that I use is sometimes parents, like they call you in and they're just like, they've had this like seal-like cough or barky cough for days now, but then you go in and they like don't cough for your entire exam. Certainly if they're stridering, that's another thing, but like sometimes if you're curious if this cough is truly barky, if you're kind of questioning, is this really stridering they're doing, or is it something else? A really way to hear that cough is to kind of gag them with a tongue depressor. So as I'm like looking in their throat to see if, another important point, if you look, I always think it's valuable to just take a quick look in their throat. I think you should anyway, just to see if there's any lesions back there, what it looks like. But, there have been times where I have looked back there and there was something there. So it's always good and worth it to just take a quick look. And then I also just wanted to mention that only give racemic epinephrine, which is, what kind of like the anecdote is for an upper airway obstruction caused especially by like an infectious process, such as croup, which is commonly what we see. Only give racemic epinephrine if the stridor is present when the kid is calm. This is sometimes kind of hard to gauge because again, a lot of kids are just screaming their head off the moment you walk in the room. But I think it's important to just, to make that decision and try to optimize the conditions in which you're examining the patient as much as you can, and see if you can see them when they're calm. The reason why is because if you give them racemic epinephrine, you kind of bought them like at minimum a 4-hour observation period. So it does make a difference in kind of the treatment course. So racemic epinephrine, again, is still only indicated when the stridor is at rest. All right, so lower airway. So problems in the lower airway, the way you can kind of classify them is like if you do a lung exam, you have a lot of these adventitious lung sounds, crackles, bronchi, and then this is typically more the case in, or classically associated with retractions. However, I've certainly seen upper airway kids with stridor having retractions as well, but classically, you have more of a lower airway issue going on when you have retractions. Classically, asthma is kind of, the common lower airway issue that we see in children. I just wanted to point out for those of you who work in the emergency department seeing children, the addition of ipratropium bromide to a beta-2 agonist has been shown to be superior to beta-2 agonists alone. So I get a lot of like transfer calls from people saying that they gave them albuterol. If you have the option to start treating asthma with a duoneb, or basically the addition of ipratropium to your albuterol, it has been shown in children to be superior to albuterol. So you're gonna stack those every 20 minutes as your initial. So what I do for every single asthmatic that I see initially, they get 3 duonebs back to back every 20 minutes. The only kind of variant to that is that I think I put it down here. Yeah. If I have a kid who is super tight and I'm just like, wow, I'm definitely doing duonebs, but this is, a really significant asthma exacerbation. Something very quick that I think is a really good rescue med and that I do all the time is sub-Q or IM epinephrine in anaphylaxis dosing. So if I have a child with asthma who's in respiratory distress, I am concurrently giving them 3 back-to-back duonebs and IM epinephrine. And I did want to note, so I think in children, wheezing can be a little bit tricky sometimes. So children have smaller lower airway structures, right? And they trap mucus more easily. So wheezing can sound a lot more like bronchi and rales than the classic high-pitched wheeze that we typically associate with like a bronchospasm. I actually, like, during training, one of my mentors like had told me that every single when I listen to a kid, that if I hear any expiratory adventitious lung sounds, that I should assume that that's wheezing. I don't know if I'm quite there, but certainly it's not always going to sound classic. All right, so upper and lower airway. Dun, 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 bronchiolitis. So bronchiolitis is a disease entity etiology that causes upper, and lower airway obstruction. And it's most prevalent in children less than 2. RSV is a common cause, although other viruses such as human metapneumovirus and human rhinovirus have also been implicated. Symptoms can range from like mild nasal congestion to copious secretions, wheezing, or rales. And this ventilation perfusion mismatch due to obstruction causes hypoxia, rather than smooth muscle contraction of airways. You know what? I'm going to grab water. I will be right back. Sorry, guys, I should have had that in the first place. So, so this ventilation perfusion mismatch due to obstruction causes hypoxia rather than like the smooth muscle contraction that we see in wheezing. Asthma. Studies show that there is still a huge practice variation in how this is treated. Most children do not require much intervention in the emergency department. Diagnostic testing is only indicated when it's very severe or atypical. What is recommended is suctioning and spot check pulse ox. And there's this big question, like one nab won't hurt, right? But this is kind of questionable. I used to be in this camp. I would try a nab on almost all my patients, but I kind of urge you, and I remind myself to resist this temptation heading into respiratory season, which obviously, sorry guys, I am myself getting over a cold. Studies show that because the inherent variability of the disease process, it kind of really limits a clinician's ability to observe a clinically relevant response to bronchodilators. So we have to remember beta agonists have adverse effects, right? Tachycardia, tremors, hypoxemia. So we kind of have to pause and consider our evidence prior to letting that reflex that we just want to give a nab take over. So who is safe for discharge? Broncholytics should be greater than 90% on room air while awake and greater than 88% while asleep. The respiratory rate should be less than 70 per minute. That's without a sustained increased work of breathing, and they need to have the ability to hydrate. And also, really importantly, they need to have close PCP follow-up or be able to return to the ED. So I wanted to take a moment and talk about non-invasive positive pressure ventilation in kids. It's a great option for infants and children that can reduce the incidence of endotracheal intubation and the risks associated with it. I I don't know how many of you have this as an option, but if you do, this is a bridge that I use all the time in the ED now. And I've avoided intubation in so many children because of these entities, because of these tools. So CPAP provides a constant positive descending airway pressure throughout the entire respiratory cycle, as long as the patient's spontaneously breathing. It recruits collapsed alveoli, increases lung volume. It also assists with inspiratory work by unloading respiratory musculature, and it improves flow. Prevents both obstructive apnea by stenting the upper airways and central apnea via respiratory stimulation. So through these mechanisms, CPAP really improves oxygenation. It's really good for hypoxic respiratory failure. BiPAP is a more active ventilation strategy. It generates PEEP. It's kind of and then the PEEP is based on the pressure differentials you set for inspiratory and expiratory pressures. This is a more active ventilation strategy because it can generate an actual tidal volume, and it's therefore a step up from BiPAP. I mean, from CPAP. And then high flow nasal cannula, or heated high flow nasal cannula, is a great strategy that we've come to really rely on in children as a tool in our arsenal. In addition to providing oxygen at an optimal warmth and humidity, as opposed to like the oxygen that you give off the wall, it can provide some PEEP and has been shown to help liquefy and move secretions. So we love it for bronchiolitis. However, because of its delivery through nasal prongs, the pressure it provides and its effectiveness is just not quite as reliable as more conventional NIPPV methods. So it's a bridge, but the pressure and the PEEP you can get is it's super variable. If NIPPV is going to be effective for this child, for a child, they're going to have a good response typically within the first 2 hours. So if you're using this, monitor in the ED, like with obviously like clinical assessments, but I also use blood gases. I usually get them about every 30 minutes, which can be helpful. And just even a capillary blood gas, if you can get it, like just poke their finger, can be very helpful. So just a couple less considerations. So the selection of a well-fitting, appropriate sized interface is really critical. So I just posed this question to you. Are you familiar with what is available at your institutions with increased ED boarding times and declining pediatric units? I really think that this would be a great thing to prioritize making available, just because, again, it's something that we use as a bridge commonly in our patients with bronchiolitis requiring a step up in support. And it can often be a good way to a good temporizing measure. And honestly, the studies haven't exactly yet shown like a decrease in the occurrence or likelihood of needing intubation, but there's still like ongoing studies with that, and I still think, like, clinically speaking, it's a very helpful tool. All right, now for a little bit of a game. So this game is going to touch quickly upon some of the other causes of respiratory distress in kids. Why are you breathing funny? So you have a 3-year-old boy who's been sick with vomiting for days. He's sleepy and breathing at 80 a minute, not hypoxic, no respiratory history or fever. I start preparing for airway management. My nurse checks one lab and plans change. What do you think's going on? All right, so I'm seeing a lot of DKA, a lot of aspiration, pneumonia. Ingestion. Yeah, metabolic acidosis. Great, guys. Carbon monoxide, that's interesting. So yeah, so this kid was tachypnic because he had a respiratory alkalosis related to kidney. So he was breathing super fast because he was so metabolically acidotic from new onset diabetes. This is a really good mimicker of respiratory distress. And certainly something that really kind of gets me every once in a while. And usually I will luckily have one of my nurses who, like, one of those people that smells ketones really well. And they'll be like, oh, they have diabetes. And I'm like, thank God for you, because I don't smell the ketones very well. So children in a metabolic crisis will compensate with their respiratory system, right? And they'll do this better than technology will. And the reason I say this is because it is sometimes these kids, the Kuzmaling is like so kind of concerning and shocking and dramatic that you're like, oh my God, I need to intubate this patient immediately. And really they are regulating their, they're doing that for a reason, and they are regulating it better than like any sort of ventilation strategy would. So I can count on, really, I can only remember once that I've never intubated a diabetic, new onset diabetic with or a patient. I've never intubated a patient in DKA. And even, yeah, and I would urge you to avoid it as well. All right. And then another question. So you're called to assess an 8-day-old infant born full term, no complications. Parent reports pauses in the baby's breathing. What do you do? So yeah, we're having all over the kind of lots of different thoughts. Pat the baby. Is that one? Pat the baby? Oh, pediatric assessment. I was like, pat the baby, sure, that's fine. Capnography, yeah, that's a really, yeah, worker breathing, monitor ABCs. Yep, full set, yep. Okay, so let's see if this video, then we'll do it later. So really, I think the big question in an 8-day-old infant who otherwise is, yeah, was a full-term baby and no significant complications, you have to determine, like, are these pauses or change in their breathing pattern, is it periodic breathing or apnea? That's a big question. That's really the question that you have to answer. Periodic breathing, typically the pauses are usually less than 20 seconds. And kind of watching this and determining, like, it's like two huge, like, forks in the road, right? If you're like this looks like periodic breathing, then you do nothing. No intervention is required. However, if you're like, okay, this baby is having apneic events, then if it's a term infant, it is presumed pathologic, and you are, doing a full, that baby is at minimum getting a full septic workup, if not more of a workup. So that's like two very different outcomes and treatment plans, right? So if a baby is truly having periods of apnea, this is just a little trick tip. Nasal cannula can be a bridge. It can kind of offer a little bit of stimulation, like while you are setting up for further airway management, and kind of doing this workup. Really, I think the big question that you're asking yourself, and what I always ask myself with these babies is this baby ill or not? Again, you're looking at that pediatric assessment triangle, like some of you so astutely mentioned on the last slide. Is this baby gray, mottled? Honestly, sometimes with periodic breathing, they can have little transient dips in their oxygenation and associated like little bradycardias, but they will self-resolve. And a truly sick baby will not self-resolve their apneas, and their vital signs probably will not look great. You might get the history from the parents that they have continued, they're not eating well at home. They're maybe vomiting. They are like falling asleep during feeds, hard to wake. So those are all things that would alert me that this is not a well infant. Let me see if this video will work.
This is late return, 36 weeks. This is admitted due to RDS. If you see, this is how to differentiate between the periodic breathing and apnea. Periodic breathing, it will be tachypnea for 10 to 15 seconds, then pause like this baby. Then pause for 3 seconds. Again, he will come. It will be also tachypnea for 10 to 15 seconds. Then again, pause for 3 seconds. This is called periodic breathing.
So basically you demonstrated that although this is a little deceiving, right? Because this baby's on like nasal cannula oxygen. But anyway, she'll have short little periods of, it'll be like tachypnea, then little pauses, and then tachypnea again and little pauses. It is weird looking. It's not a normal breathing pattern, but it's periodic breathing and it's normal and not pathologic.
This is late return, 36 weeks. Admitted due to RDS. If you see this.
There we go. So I just wanted to, I'm going to talk about airway management next, but I just want to pause here for a second to see if anyone had any questions about respiratory distress before I go on.
There is a question about, at one point, Xopenex was used for kids, but they haven't seen it in a while. Has that been dropped?
Yeah, so Xopenex, the only indication for it, there's like, usually the only time I ever use Xopenex is because if I have like a congenital cardiac patient who for some reason, like they've determined that Xopenex is the like safest drug for them. It's so expensive and hard to access. So yeah, it just has a little bit less of the beta 1 action. So it in theory causes less tachycardia, but there's no like other like respiratory indication for it. So yeah, I still have a little bit left. Sorry, I'm not done. But so kind of PDMAS for use. Yep, I think
Hey,
I-
Emily, this is
Yeah.
Sam. I don't mean to be rude and interrupt, but you have so many excellent questions.
Yeah, you know
Will
what?
be
You're
able-
right. I think
if
I'm
you
gonna
can-
go on.
Yeah,
Mhm.
you finish your next part and let's use these questions to steer some of your dialogue at the end so that we can
Okay.
make sure you finish your session. Yeah.
So let's talk about PEDS airway management then quickly. Why is it challenging? So we're going to talk a little bit about anatomy and physiology here just because I think it's really relevant and helpful to know. So we have that famous aphorism, right? Children are not just little adults. And that's true until about age 6 to 8. Until they are elementary sized, at least once they get to elementary size, their airway anatomy is pretty similar to an adult. So kids less than 6 to 8, less than elementary age though, they have some important anatomical differences. They have very, much smaller, relatively smaller nasal passages and cavities that cause increased airway resistance. And it's really estimated that the nose contributes up to 50% of total airway resistance in younger children. And really kind of what that results in is that they are preferential nasal breathers until about 6 months. So mild obstruction can cause significant distress. This is why suctioning bronchiolytics can actually be so helpful. I find nasal pharyngeal airways really helpful to use. And in circumstances where the child will not pull it out immediately. And it can kind of help stent open those airways in children or in babies. I use 14 French. And then suctioning. So some other points, infants have really big tongues, prominent occipits, short necks. And they're basically when they're supine, it's not an ideal airway position. So this makes their airway anatomy much more difficult to visualize with direct laryngoscopy. So I'm going to take you through a couple things to set you up for success if that's something that you are undertaking. This picture on the left just shows how a towel roll under their shoulders can neutralize that position and put their airway into a more ideal alignment to help optimize your visualization. And then I really like this picture on the right because this is kind of what I do. I do use the towel roll, but I also will put my other hand that I am not intubating with underneath the baby's head. And again, it kind of helps me move around, if I don't need to strictly keep C-spine precautions, that's a whole other issue, but it helps me keep some alignment, and it can help me position things. Sometimes if I even just move the head a little bit, it'll bring the airway into more clear visualization. This just shows how how floppy the epiglottis is in infants. And then also how, so in an infant, the vocal cords are much more posteriorly located, so not quite as obvious in an adult, right? And also in adult, they're nice, pearly white, super obvious, and not so much in an infant. So it's just, yeah, you can see how it's just more difficult to visualize the airway. So these are just some additional kind of tips and tricks that I've learned over the years, especially in airway management. Meant to put this in the respiratory distress section, but anyway, febrile children appear to have respiratory distress. So when you're trying to make that determination, make sure that you get them afebrile through the use of antipyretics before you're trying to determine if they're very tachypnic or not. Again, bronchodilators will often cause a transient dip in SpO2 due to a VQ mismatch. So don't be shocked if after you give your asthmatic 3 duo nubs, their oxygenation drops a little bit, and that's normal and something that will resolve over time. Oh, and then this is actually airway relevant. Bag valve mask is a 2+ person job. It's really hard, even with appropriate pediatric size masks, to get a good seal. And so and not just that, sometimes especially kids with their like floppy heads, they'll just be really difficult. Like you need someone who's going to be like doing the chin lift, jaw thrust with your mask, and while you're like actually providing them with the positive pressure. And I really just think that it's more than a 1-person job. I think it's very difficult to do just by yourself. So as I mentioned earlier, we're seeing more and more of these medically complex patients. So I just wanted to take a moment to talk about trach obstructions. This is a really scary situation if this ever comes into your emergency department. So parents should honestly be very like, before their child with a trach is discharged from the hospital, usually they're given extensive training on this and how to deal with it. But you always have to be prepared to deal with it if they aren't able to. So parents will usually have extras. They're supposed to have extras of their appropriate sized or like their replacement trach. But if you have a trach obstruction that you cannot clear with like suctioning alone, you need to, like, I recommend positioning them again with a towel roll, extending their neck, try to suction, try to bag. If you need to replace it, their trachs often have inner cannulas that can be replaced. You can use an obturator that you see kind of in the picture on the bottom right there. And if you cannot replace this trach, you can try a smaller cuffed ET tube or even a catheter connected to an oxygen source. If all else fails, what you do is you block their stoma and you bag from above. So that's kind of like walk you down the quick and dirty of how to deal with these trach obstructions on the fly if you have to. Okay. I think that's, oh, yep.
Hey, Emily.
Uh-huh.
This is Sam. I see that you're kind of getting to check some things out here. I'm going to let you kind of decide which way you would like to go. So we have a lot of questions that attendees have been typing into our Q&A. And I know you have your questions too from Slido. Is there a way you would prefer to address, like we can either field some to you, or we can go to your Slido questions and use that to drive it? Either way, whichever questions we don't get to, as long as we can capture them, if you can help us capture the Slido ones, we'll capture ours. You'll get to fill those questions in and send it out to all the attendees too.
Okay. That sounds good.
Whatever you prefer.
Yeah. I'll just look through these quick. Yeah, it's working. I'll go through these quick, just like to see, and then I'll have you go through the Q&A.
Okay, sounds good. We got about 10 minutes, so you have plenty of time.
Perfect. And thankfully my bronchospasm has apparently hopefully resolved. So how would you use an experienced provider edit the pediatric assessment form for children with special needs? I mean, I still think that it applies to children with special needs. I mean, I think, they still will have retractions sometimes, their parents will be able, their caregivers will be able to tell you like, hey, they're working harder to breathe than usual. Usually they're very savvy at being able to recognize that and identify that. So I think that it's not exactly an editing of the pediatric assessment triangle, but that's just like with these special needs children, I really do a lot rely on like caregivers to tell me like what the changes are. What is hand heavy? Is that like a
Hand heavy is a mobile tool that can assist with protocols and medication dosing for patients in the field, but it is something that not all of our states have.
Okay.
Yep.
I will have to become more familiar with it. Try not to panic, absolutely. Yeah, so successful and child dies because they didn't get oxygen and ventilation. Yeah, so I think this, I don't know how many like pre-hospital providers are on this, or on like this in this talk tonight, but I especially think that this is like really, again, as far as airway management is concerned for children, preparing and setting yourself up for success is so crucial. Bag valve I mean, there are bag valve mask is, or like providing like positive pressure ventilation by other means is certainly you know, an option. And for pre-hospital providers, I really think that all of the evidence suggests that, you know, not making intubation a priority is actually really better for outcomes. So I would especially recommend avoiding intubation in the field if possible. Yeah, sorry. So I didn't address this before. Brew or brief resolved unexplained events. For EMS, what can we look for? Well, honestly, I just think for brews, it doesn't matter anyway, because really for brews, what we're trying to determine is if they meet low risk or high risk criteria. So I think in the they're going to have to be assessed in the hospital anyways. So really, it's just, yeah, we're going to have to assess them in the hospital anyway and determine if they require to be admitted or not. Honestly, a lot of times they do, and a lot of these patients are just admitted. So there's nothing like, as far as like an EMS provider that you really need to distinguish as far as a brew. Obviously, if they're apneic and not breathing, then you just go down your pediatric your, you know, PALS algorithms. I don't have a specific criteria for utilizing high flow nasal cannula. It is more to augment work of breathing. It provides oxygenation, but I mostly use it in the setting of increased work of breathing and wanting to kind of provide I don't know if I mentioned this in my slide, but like, so one nice thing about heated high flow is that like it really it optimizes like the nasopharyngeal dead space. So you can oxygenate it helps you like oxygenate through that. And kind of the pressure even from the high flow kind of moves that fluid and mucus out of their airways. So I use it, when basically they're still having significant respiratory distress and like obstruction from the mucus despite suctioning. Using an OPA or MPA with BVM, I think is very helpful. Bradycardia does often follow apnea, not always, but it definitely can, especially in very young infants. Critical pediatric patients being transported by specialty teams versus, I don't really feel like super, I don't feel like educated enough to honestly comment on that. I'm not like, not a pre-hospital provider, so, intubation appropriate. Let's see if I can go back. All right, this is probably a good idea. If you have any, like, really, since I only have 5 minutes left, Sam, if you have any anything in the Q&A that
Absolutely.
can I open it up or?
No, we'll field them to you. No worries. We
Okay.
have a couple folks here, other EMSC managers that are handling that. So they will field you any relevant questions if they have them. We'll just pause for that.
I think we're ready.
Oh, go ahead, Chetty.
Oh, sorry.
No,
How do you remember the congenital heart defects? Which ones get oxygen? Which ones don't?
Yeah, honestly, this is cannot be answered honestly in a few minutes. And it really depends. It depends on where they are in their surgical palliation stages. So I would be happy to come and talk to anyone about congenital cardiac defects and how to treat them. But really, I guess if you want to bring it back a little bit to physiology, oxygen is a pulmonary vasodilator, right? So any condition that you are getting over perfusion to the lungs, you would not want to use more oxygen, because that's just going to basically make the condition worse. Does that make sense? I don't know. That's basic, but yeah.
Which type of suction do you recommend? Bulb versus nasopharyngeal with suction cath?
I usually, it's tough, right? Because we use off the wall nasopharyngeal suction, the little catheter, French catheters, usually in the hospital, and then the parents are just like, well, we want this for home and we aren't going to be able to do this for at home, in which case I highly recommend the nasal Frida, since I think that works better than bulb suction. I recommend that that's the brand name, but any sort of nasal suction device that the parent, they have that little straw, it's not a straw, a tubing, and then you put it in your child's nose and then you yourself suck on it. That's so much more effective than the bulb suction. But in the hospital, I'm usually using off the wall suction.
With a high flow nasal cannula, how many liters per minute are you using?
1 to 2 liters per kilo per minute. So it depends on their weight.
And then would you suggest an educational reference for converting a capillary blood gas analysis to arterial analysis?
Yeah, I'm never using arterial. I rarely ever get blood gases for arterial analysis. I've used both capillary and venous. I think capillary is really great if you just because it doesn't even require any IV or any venous access. You can literally just poke their heel or their finger. And I'm not using it to determine oxygenation. I'm really looking at it mostly to determine if they're effectively ventilating. So I'm looking at it for their PCO2, which should be pretty comparable in capillary and venous samples.
And I think that's it for the chat or the Q&A questions, excuse me. Thank you.
Yep.
Perfect. All right, Emily, thank you so much for rounding out the end of our clinical education tonight. You're more than welcome to jump off. I want to say thank you for your time. I'm going to kind of transition into housekeeping for our folks, make sure they have their instructions for CEs and survey. So you are welcome to hop off if you would like.